We'll have two lectures this morning. We'll start with keratoconus. Once we're done, the next one is what? Neonatal conjunctivitis. That will be the second lecture. So we'll start with keratoconus, the neonatal conjunctivitis. These both the two diseases are very, very common. Wherever you'll be working, you'll find them. Here we go. Keratoconus. The definition of a keratoconus is a cone-shaped cornea. And when we're talking of a cone-shaped cornea, the front of the eye is the cornea, which is transparent. It becomes cone-shaped, like a cone. This is a progressive disorder. Doesn't occur overnight. Slowly, slowly, the cornea will assume a conical shape because of the stromal thinning and the protrusion which occurs. Both eyes are normally affected, and this is an inherited condition, autosomal dominant transmission with incomplete penetrance, transmission from the parents, obviously. Presentation typically it's during childhood or puberty with unilateral impairment of vision due to progressive myopia and astigmatism. As the cornea protrudes outward in a conical shape, then you have these features. Impaired vision, they can't see properly. Usually one eye more affected than the other, but you can get it in both eyes. So you have normally unilateral impairment, but it does occur in both eyes. And the impaired vision is because of the myopia which occurs and the astigmatism as the cornea is protruding outward like that. Approximately 50% of the normal eyes will progress to keratoconus within 16 years. This is how common these things are. Diagnosis, the main features on the cornea is there is central or paracentral stromal thinning and the protrusion of the apex of the cornea, the center bit, it starts protruding outward. And this gives you irregular astigmatism when you do the refractions. This is a cross section of the cornea, keratoconus histology. You can see the central part is thinned. This is the peripheral part which are thicker. There's protrusion of the central part and it thins out like that. This is a cross section. This is the front. This is the lens here. Keratometry readings normally grading -48D is mild, 48 to 54 is moderate. Usually in severe cases, you have over 54D diopters. Clinical signs of keratoconus, it gives you what we call oil droplet reflex. When you get a direct ophthalmoscope and at a distance you want to look at the cornea, the central part appears like a drop of oil which has dropped into the eye. That's what they call oil droplet reflex. So you should be able, everyone should be able to tell that this is keratoconus simply by getting an ophthalmoscope. And you look straight ahead and the patient will be looking straight. You will see that oil droplet reflex. There, this is keratoconus. No one should miss keratoconus. oil droplet reflex with a direct ophthalmoscope at a distance of about a foot. 2, you have irregular scissoring reflex seen with a retinoscope. When you use a retinoscope, you have pushing the reflex across the cornea. You have that scissoring reflex. And on the slit lamp, you find fine vertical deep stromal stress lines within the cornea. These lines disappear with pressure on the globe. These lines are referred to as Vogt striae. So when you hold, when you see that on the slit lamp, when you press on the eyeball, they sort of disappear. Epithelial ion deposits around the base of the cornea is called Fleischer ring, but seen with a cobalt blue light, not the white light. Progressive corneal thinning, maximal at the apex, at the apical zone of the cone, and associated with the following: poor visual acuity, irregular myopic astigmatism, high keratometry readings, and bulging of the lower lid in down gaze. I think this last bit is the easiest way to make a diagnosis of a keratoconus. You simply ask the patient to look ahead, then ask them, can you retract the upper lid? Can you look down? They will look down. You will find that the lower eyelid, there's that V shape of the lower eyelid. Because of the protruded conical cornea, now is pressing on the lower eyelid. It gives you that V shape. Bulging of the lower lid in down gaze. That's what is called the Monsoni sign. It is always there, especially in most of the cases. Severe cases, in severe cases more. Where are we? Here. Okay. This is what we are saying, keratoconus. This is the Monsoni sign. You ask the patient to look down. You can hold the upper eyelid there. You can see this V shape. This occurs because of the protruded center part of the cornea is pressing on the lower eyelid, and it forms that V shape. That's the Monsoni sign. So you don't need anything to prove the diagnosis. You simply ask the patient, look down, you get it. The rest is manure. You should be able to get along easily. These are patients who come with poor vision. Before you start, no, let me refract. Yeah, can you look down? This is keratoconus, sit this side. Because when they go for refraction, the improvement is not much. It's not much. Most of these patients will have to end up with a cornea graft. You cut the central bit, you put the graft there, and the suture that flattens that protrusion and improves the vision. The corneal topography shows irregular astigmatism, most sensitive method for detecting early keratoconus and monitoring progress. Acute hydrops. This is caused by rupture of the Descemet's membrane. Descemet's membrane, you know there's epithelium out there. Descemet's membrane is down there behind, isn't it? When there is that rupture, it leads to influx of the aqueous into the cornea. And you have like a edematous cornea, what we're referring to as acute hydrops. And this can occur suddenly. Any rupture there allows the aqueous to go through the cornea, and the whole cornea now becomes opaque because of fluid which has entered the cornea. That's what is referred to as acute hydrops. Break usually heals within 6 to 10 weeks with the following result. Once that, there is always cornea edema clears, stromal amount of stromal scarring, stromal amount of, no, it's I think not stromal of stromal. A small amount of stromal scarring may develop, not stromal. Let me put it this. Let me correct this one. Double M, is it? Small.
You want to say?
No, I want first to correct.
You want to say small?
Small. SI.
Like that?
Yeah, okay. There is a small amount of stromal scarring. Self now. Self. Acute episode treatment, usually you give cycloplegic eye drops, hypertonic 5% saline. This hypertonic 5% saline helps to remove some of the fluid from the cornea. Or ointment and patching will help that. You can use a bandage contact lens. Bandage contact lens, what it does is just flattens the front of the eye. Healing may result in good vision later on. This is the histology part. You can see keratoconus histology. The basal cells are here with a lot of edema. These are like balloon cells. They've got edema. This is the epithelial part. These are ballooned because of the fluid from the anterior chamber coming into the cornea. Keratoconus, you can see severe edema. The whole cornea becomes edematous white. You can't see properly. Vision is affected, obviously. This is scarring which occurs after the edema has gone. You can remain with this scar, and it's not a pleasant thing because the vision here won't improve if you remain with a scar. Clinical associations of keratoconus, things which can occur. You have got venous keratoconjunctivitis. This is allergic conjunctivitis. Can go hand in hand with keratoconus. Blue scleral aniridia, ectopia lentis, retinitis pigmentosa, congenital amarullosis, systemic associations, Down's syndrome, Turner's syndrome, Marfan's syndrome. I have seen Marfan's clearly. Atopy, this is where people are allergic. Mitral valve prolapse and mental retardation may be an associated condition in these cases. One case may not have all these, but these two occur, maybe they can have one or two. Yeah. It's not that they must have all of them. Keratoconus. How do you manage keratoconus? I think the first point is to determine the refractive error of the patient. Do a retinoscopy and do subjective. You must have the readings there. You do,
Where is the mitral valve found?
Yes, where is it? What is your anatomy? Mitral valve? There are two valves, isn't it? Tricuspid and mitral valve, isn't it? Between the chambers, atrium and ventricle. I don't know whether it's the right one or the left one, which is one is mitral valve.
It's in the heart.
In the heart, yes, inside the heart. Well, you can have a valve anywhere else. It's only the heart which has valves.
He has even exclaimed that,
Valves are in the heart, old chap. Management. The first thing you do is a retinoscope, like you are doing retinoscopy to improve the vision. After that, you do subjective. Spectacles and soft contact lenses can help, generally sufficient in the early stages of the disease. Once it goes to the late stage, even if these lenses won't be of any use. They're not very good. You just have to do penetrating keratoplast. In the center, you remove that central part and put a cornea graft, which flattens that cone and improves the vision. But to do that, you must be in a country where they do cornea grafting. You know? Spectacles generally required for high degrees of the rigid contact lenses may be used for high degrees of astigmatism to provide a regular refracting surface. These have to be rigid. They sort of flatten the front of the eye and improves the vision. But this one is the most preferred mode of treatment for keratoconus, keratoplasts. And it's normally penetrating keratoplasts. You penetrate the whole cornea, remove the central pit, then get a graft from somewhere, another cornea, and you suture through. Once it heals, that protrusion flattens out and the vision for the patient improves. Penetrating or deep anterior lamellar keratoplast. Deep anterior is contraindicated if patient has had prior attack of hydrops. Descemet's membrane has been damaged. There is 90% success rate with this deep anterior lamellar keratoplast, 90% chance. But I think there is a higher percentage chance of success when you do a complete penetrating keratoplast graft.
There's
a question. Intracorneal ring segment implantation can help to flatten the cone.
Number 0977 220770.
I think he's doing what?
No, it's somewhere else.
Kwamana. Any questions, ladies and gentlemen? You see, in Zambia, operations like this can be done, but how many of our people are ready to donate tissue? Zambians, we tend to have that traditional attitude towards, nobody would any so shine. Even if you have no use for it, and your friend can benefit. We have a big problem with Zambia. Grafting, too much suspicious. Everything in witchcraft. You can't live like that. But meanwhile, when you're here, you'll be bothering the government. No, I would like to be sent to South Africa for a cornea graft. Questions, ladies and gentlemen? This is keratoconus, conical protruding cornea. Which is the next one? Must be in the money. Hmm?
Di quando?
You see?